Good morning. McGill University is on land which has long served as a site of meeting and exchange amongst indigenous peoples, including the Haudenosaunee, people who are building the Longhouse, and Anishinaabe nations. We acknowledge and thank the diverse indigenous peoples whose presence marks this territory on which peoples of the world now gather. Bienvenue à toutes et à tous à l'Atelier canadien d'Oncologie mondiale. Welcome everyone to the second day of the Canadian Global Oncology Workshop. The Gerald Bronfman Department of Oncology at McGill University is extremely happy to host the global oncology community in Montreal and virtually. For those of you who were here last night, hope you enjoyed the great talks and dinner last evening. So I'm going to start with a few housekeeping points for those who are attending in person. Breakfast and snacks are served outside all morning. We've also reserved a room on the 5th floor, room 519, in case some of you need to take phone calls or have some work to do. Although we hope you'll stay with us during the whole workshop. At noon, we will break for lunch and head to Thompson House. It's a 7-minute walk from here, and we will resume the workshop at 1:30. If you have any question after each session, for people who are joining us virtually, you can write them in the chat on Hopin. And for people who are here, you have to use the microphones. We have a couple of microphones around the room because that allows the virtual attendees to actually hear your questions. We also encourage live attendees to log in to Hopin if they want to chat or participate in chat with the virtual attendees. So we'll start the day today with our second session of the workshop titled Pandemic Recovery in Global Oncology, which is chaired by Dr. Talia Malagón, who will introduce herself and the speakers. Thank you.
Thank you very much. So I'll just introduce myself as chair. I'm an academic associate at the Division of Cancer Epidemiology here at McGill University. And I'm also going to be one of the speakers today at the end of the session. So I'll be presenting some work I've done in the context of the McGill Department of Oncology COVID-19 and Cancer Program, looking at predicted impacts of the COVID-19 pandemic on cancer mortality in Canada. So we have two other speakers today, two of them also being pre-recorded presentations because, as the title suggests, it's global oncology, so they're international speakers. And even though we tried to entice them to come here, they all have important things to do back at home. So our first speaker today will be Dr. Cristóbal Cuadrado, who is the Undersecretary of Public Health in the Ministry of Health of Chile. And he was also previously a research fellow at the Center for Health Economics at the University of York and an assistant professor at the School of Public Health at the University of Chile. And so his research will deal with pandemic recovery and the impact of the pandemic in Chile, obviously, and his research interests include health economics, health policy analysis, policy making, and comparative health systems. Our Dr. Cuadrado, unfortunately, will not be joining us live today, and so he will not be able to answer your questions, but we're just very happy to have his pre-recorded presentation and on his very important work. Our second speaker will be Dr. Partha Basu, who is the head of the Early Detection, Prevention, and Infection branch at the International Agency for Research on Cancer in France. Dr. Basu is well known for his research that has informed several guidelines and recommendations from the World Health Organization in saving women's lives from cervical and breast cancers, and he's leading the implementation of research programs aiming at improving cervical cancer screening in vulnerable women in Europe and in India. And he's significantly contributed to building capacity and delivering quality-assured cervical and breast cancer early detection services in several low and middle income countries. So Dr. Basu will be presenting a case study from Bangladesh today. And even though he has a pre-recorded presentation, he's told us that he will try to attend the session live as well, so he may be, we'll check throughout the session to see if he's there to answer your questions at the end. And I decided I would present last because I wanted to give the full time to our pre-recorded presentations. I can always adjust my own presentation, and to meet the allotted time period if ever our pre-recorded presentations are a bit longer than expected. So join me in welcoming the presenters who, well, they're not here, but we're very grateful to have their presentations.
Hi, everyone. I'm very glad to be able to join, at least virtually, to this Global Oncology Workshop 2022. My name is Cristóbal Cuadrado. I'm currently the Undersecretary of Public Health at the Ministry of Health of Chile. Today, I want to share with you some of our research on the last years on the impact of the COVID-19 pandemic on cancer care access in Chile. Lessons from an unequal country. Just a brief note on our beautiful country, Chile. We are located in the southern corner of South America with a population of roughly 19 million persons. In terms of healthcare, is a very segregated health system with a public health system covering nearly 80% of the population. The insurance is called FONASA. You will see in some of the presentations, the public insurer, and also a set of private for-profit insurance covering high-income population for the 15% of the high-income group. This produce a lot of inequalities in terms of access to healthcare, something that has been a chronic problem in the country. And we have explored these inequalities in terms of the type of insurance of the population to do some of the analysis that we are going to present. In terms of the methods, just a very brief note, we have used an interrupted time series analysis approach with a particular parameterization proposed by Xiao on 2020, using GLM models with a binomial negative structure with our exposure to be defined as the initiation of the pandemic, in the case of Chile in March of 2020, using this standard regression approach. And we analyzed the number of events of ambulatory services, sick leaves, diagnostic confirmations, for different groups: general population stratified by sex, health insurance, public insurance FONASA, or private insurance ISAPRE, and also different age groups to analyze how much the pandemic impacted in the production and accessibility of different oncological services, ranging from ambulatory services to inpatient care, and also diagnostic confirmation for different type of cancer. So the first part of our work has been published on 2021 in BMC Public Health. You can find there the complete publication, and it covers different time-sensitive conditions, and we have this defined time-sensitive conditions as some of conditions that require an rapid diagnosis and management to avoid disability and long-term consequences. So we have packed here major cardiovascular events like myocardial infarction, stroke, but also an important list of cancers. Here you have in the red lines the trends that are observed for the period of 2017 to 2019, and you have in green lines the observed effects during the pandemic during the year 2020. So broadly, you find that in all time-sensitive conditions, you see an important drop of the number of diagnostic confirmations in Chile, and this is particularly intense for some conditions like gastric cancer, colorectal cancer, with a minor effect on lymphomas or leukemias, for example. And here we see some kind of trends that for the events with more acute presentations, for example, leukemias or strokes or myocardial infarctions, you can see that the pandemic has impacted less in comparison with other cancers that has a development in the natural history that is slowly in terms of. Something that we explored also in this paper is the differences in the impact between men and women, and here we see a similar graph but with different colors. And so I want to point you the case of the woman, where you see that the drop that is represented in the red dots is much greater compared with men. So in relative terms, women were far more affected by the disruption of services and this is summarized in this table, where we estimated the absolute reduction in confirmed cases during the first half of the first 6 months after the initiation of the pandemic, and you have it in this column for men, this column for women, and in this column the excess impact on women in terms of excess cases of cancers, for example, that were missed for women, that in addition of the cases that were missed for men, assuming that the disruption of services you could have expected that will affect similarly men and women, but that hasn't been the case. And that's an interesting discussion of what are the drivers for that in terms of health-seeking behaviors, or how the supply of services is guaranteed for certain population in context of emergency. More recently, this year, we have published another piece in the American Journal of Public Health entitled "Cancer Care Access in Chile for Vulnerable Population," where we expand some of this analysis, particularly for cancer. And here you have the time series for three important type of services for cancer care. In the top panel, you have diagnostic confirmations. They are mandatory in Chile for a set of priority conditions. All the conditions that we are analyzing here are among that list. And you have in the red line the observed trends in the previous years, and in the green the trend observed in 2020. So and you see also in this pale green with dotted lines what is the counterfactor, what we will expect on normal 2020. So the difference between these dotted lines and this solid green line represented all the cases that were missed during this year for the country. You can see also the effect in outpatient services in terms of visits, diagnostic tests, and other services. Also a very, very important effect that only in the later part of the year is started to come to a catch-up in terms of the number of outpatient services. But this is not correlated with a catch-up in the diagnosis completely observed for the cancer confirmations. And for sick leaves due to a cancer diagnosis, that's another data set that we have available. Um, it's interesting to see that we don't see any recovery across the year in the terms of the sick leaves that were provided due to cancer. And this is important because usually sick leaves are provided to cancer patients in the more active treatment period. So this is an indication that the patients, particularly the newly diagnosed patients, were not identified. So the incidence of the cancers were missed mostly, and also that the new cancer treatments were not offered during 2020 to newly diagnosed cancer, something that is really problematic. This figure, you can find it in the supplementary material of our last paper, and you can see the same figures for a set of different general oncological services and services for specific cancers, where you see very similar patterns across different type of ambulatory services. It's important to notice that we have identified that inequalities in terms of the impacts are present not only by gender, but also by the type of insurance. So let's see first in terms of gender, we find that the reduction of outpatient services in relative terms during 2020 was roughly 43% less than what was expected, and 39% reduction for males. So a 5% difference. And in terms of cancer diagnostic confirmations, the difference is even bigger, with an 8% difference between these two groups. We didn't find differences for cancer sick leaves between females and males, with a roughly 30% reduction. In terms of the insurance, there are some interesting issues we identified. First, the patients from the public insurance were more profoundly affected by the pandemic, with 34% reduction in cancer sick leaves and 52, almost 53% reduction in cancer diagnostic confirmations during 2020. But this is not what we observe in terms of cancer-related outpatient services. So private patients were more profoundly affected in terms of their access to outpatient services. But in relative terms, public insurance patients were more affected in terms of having a diagnostic confirmation or cancer treatment initiation. Remember that sick leaves for us are an indication or a proxy of that. And how we can reconcile these two observations? Well, private insurance patients are accessing more intensively to services, some of them that are not fundamental for some of the care. So you see that even a small fraction of the reduction of the access to outpatient services have a very strong correlate in terms of the accessibility to critical steps on the diagnosis for cancer patients in the public system, something that is not as intense in our private sector. So here again, the inequalities of our country in terms of the structure of the health system are also reflected in terms of how strongly the impact has hit of the pandemic in cancer care. This table that you can find it also in the paper, you can see also the relative risk ratios that we estimated of the impact from the pandemic, comparing public and private insurance. So this is a very extreme case in colorectal cancer. The increased impact of the pandemic in terms of reduction of diagnostic confirmations for public insured patients were ninefold the impact in the private insurance population. And you can see some of the pattern in most of the cancers, not all. For example, leukemia have some differences. We want to also to explore in which moment of the first year of the pandemic this impact has been produced more intensively, and here you have in red the percentage reduction of the cancer-related services compared with were expected in or counterfactual. So you see that before the initiation of the pandemic, this is February 2020, and this is already March 2020. You see that you don't have any reduction in terms of what we were expected for a normal year, but after March, you have an immediate onset of the reduction and the disruption of services. And this is also seen for diagnostic confirmation and not as intensively for sick leaves, and the effects on the reduction of sick leaves access was intensified due to the year. Again, concordant with our interpretation that this can be a proxy of the acute initiation of treatments or during the acute phase of treatment of cancer. And in green lines, you have the cases of COVID-19 in the country. So you see that the first wave that come in the winter in the southern hemisphere in Chile were come after the greatest impact of reduction of services. So the services in terms of both the supply and the demand changed very shortly at the initiation of the pandemic, and this is related with the fear of contagion. So people didn't want to go to services, but also the services were less available very rapidly after the initiation of the pandemic. We have also explored, and this is a bonus track, the relationship, this is an association, just a correlation between the two variables on the excess deaths and reported in 2020. This is the x-axis, and the unmet demand reported in surveys in different countries of Latin America. And you see a very strong correlation between excess deaths and unmet demand. This is not only for cancer, but about all type of services. For a selected group of countries that we have disaggregated data, we have also looked at this using an objective measure of full service disruption. This is the inpatient care for time-sensitive conditions. Here you have a stroke, here we have cancers, and here you have infarction, myocardial infarctions. And you see that, for example, for a stroke, there is a very strong correlation, almost perfectly, between the health services disruptions in inpatient care and the excess mortality for 2020 year. So this is an important issue to look. Countries that were more severely affected by the pandemic in terms of the impact of the virus itself, but also were less resilient and with weaker capacities to respond to this threat, they impacted much more deeply in terms of the mortality, not only represented directly by COVID deaths, but also for excess mortality due to other diseases, and other diseases like, for example, time-sensitive conditions that were not treated on time and represent excess deaths. Interestingly, when you see different type of reasons for the disruption, and thus this comes from surveys from the World Bank, and again we associated with the excess deaths, you see that the lack of enough medical personnel, and the fear of contagion were the most likely predictor of excess deaths, but not the lockdowns or other non-pharmacological interventions that were applied. So this is again a strong case to look at how the pandemic has been managed during this period to understand how this. And we had three treats for the long terms as well. This is the papilloma vaccination program coverage in schools in Chile. And you see that we have nearly between 80 and 90% coverage previous to the pandemic, but this can have reduced to around 70%. And this, as in other areas, represent long-term threats for the or results in terms of cancer care. So, take-home message: we have profound and unequal impacts. Women's and low-income population in Chile were more severely affected in their access to time-sensitive conditions, particularly cancer care. There were uncertainty and health system preparedness issues that were key factors to explain this. We have ongoing threats for long-lasting effects that needs to be taken into consideration as the vaccination uptakes and screening. And there are strong social protection systems that are required to reduce the impact of this pandemic and potential future threats. And this is something that we are working in Chile, and it's important to work across the globe on. Thank you very much for your time, and I'm sorry I'm not will be to join there and have some question and answer, but I hope that you will have a very interesting discussion on the path.
So thank you very much to Dr. Cuadrado for having agreed to give us this presentation and to take time out of his busy schedule as Undersecretary of Public Health. So certainly I found the last results on the drop in HPV vaccination coverage very concerning as someone who studies HPV vaccines myself. So our next presenter will be Dr. Partha Basu, who will be giving us the perspective of what was happening in Bangladesh during the COVID-19 pandemic.
Good morning. At the outset, I thank the organizers of the Canadian Global Oncology Workshop for inviting me to deliver this talk. The COVID-19 pandemic undoubtedly has been the worst public health crisis of our generation, claiming more than 6.6 million lives till date. More importantly, it has stretched the health systems to the extreme, especially impacting the cancer screening and other preventive programs. But then there are instances of resilience, especially coming from the low and middle income countries. One of such lower middle income countries is Bangladesh, situated in Southern Asia. It's a small country by area, but then it has a very large population of 166 million people. The National Cervical Cancer Screening Program in Bangladesh was launched in the year 2005. The program stipulates that women between 30 and 49 years of age will be screened every 5 years with VIA. The VIA positive women are advised to attend the designated colposcopy center where the treatment is offered on the basis of colposcopy. The program started with a pilot in 2005, and then it was gradually scaled up across the country over the years based on the lessons they learned from evaluation of the pilot. And because of this steady scale up of the program, you can see that every year the number of women screened is gradually increasing. The screen positivity rate remains more or less steady around 5%. The scale-up approach of the program was kind of unique. It had a top-down approach in which the screening centers were initially set up at the medical college hospitals and other tertiary care centers, the district hospitals, the maternal and child health centers. And these centers get a large number of women coming there for various reasons. So initially these centers were the screening centers, and the women, the VIA positive women, they were referred for colposcopy, and for colposcopy centers were set up across the country. As you can see on the in the map on the right hand side, there are colposcopy centers. Some of the centers still do not have loop excision facilities, but they have facilities for doing ablative treatment. And these centers are spread out all across the country. Gradually, as the program was scaled up, the screening facilities were set up in the primary health centers and even in the sub-centers, which are the last mile health facilities. Health information system is a key requirement for a screening program to achieve high coverage and also provide services with quality. Measuring the performance of the screening program requires collection of individual level data using a robust health information system, and this is a major weakness of most of the LMIC screening programs. The DHIS2 software is the world's largest health information management system that was developed in technical collaboration with University of Oslo, and this is provided free of cost by the World Health Organization to different countries across the globe, especially the low and middle income countries. And if you see the map on the right hand side, you will appreciate that a large number of countries, they are already using this system for the monitoring and supervision of the maternal and child health programs, and they have used this very successfully for COVID-19 surveillance, COVID-19 vaccination program. This DHIS2 software has a module that can be customized to measure cervical cancer screening activities. In 2018, even before the pandemic started, Bangladesh introduced this module to collect individual level data. So initially they started collecting this data at individual level at the district level facilities. Because of the installation of the DHIS2 and scaling up of the same information system across the country and then across the different levels of health facility, Bangladesh could report the impact of COVID on cervical cancer screening in a quantitative manner, which is not available from too many LMICs. As you can see in this comparative graph, there was a clear dip in the number of women being screened every month starting from March 2020 when the COVID struck. For full 1 month or even a longer period, the screening activities were almost stopped. But then what is interesting is that starting from August 2020, the screening activities regained almost the pre-pandemic numbers. So as you can see here, the graph showing the number of women being screened in 2020 was almost as high as 2018 or 2019. So how did this happen? It was essentially because the program management took a very, very pragmatic decision in the face of the pandemic. As you know, at least in the initial phase of the pandemic, it was more of an urban phenomena affecting the highly populous cities more as compared to the hard to reach more rural areas. So the program decided that it was an opportunity to cover the hard to reach areas where screening activities were extremely low. So the more of the screening facilities were set up and more resources were kind of diverted to screen women who are there in the northern part of Bangladesh, which is more hilly, more rural, more hard to reach. And because of that, even though there was a significant drop in the number of women being screened in the southern and urban part of Bangladesh, there was actually a significant rise in the number of women being screened in these hard to reach areas. The colposcopy attendance was significantly impacted across the country. Women were advised to, VIA positive women were advised to go to the colposcopy centers, which were situated in the urban areas mostly, and because of that, there was poor attendance to the colposcopy clinics. And as the program realized this problem, they also made a very pragmatic decision to move from screen, colposcopy, and treat approach to screen and treat approach, where the VIA positive women were immediately assessed for ablative treatment. If the woman was eligible for ablative treatment, thermal ablation was done at the screening facility itself. So that cut down the referral to the colposcopy centers. We have not yet been able to measure the impact of this, but then this was again a very pragmatic decision by the program. To summarize, let us see what are the positive things that happened in the cervical cancer screening program in Bangladesh. First and foremost, the program did not lose its priority. Secondly, as I mentioned earlier, there was a strategic planning to prioritize the hard-to-reach women, and in fact, taking the advantage of the pandemic to cover the women who are traditionally remaining outside the screening continuum. The women at the time of pandemic were naturally very scared to go to the primary health centers. So the program management decided to set up temporary clinics. These temporary clinics, especially in the hard-to-reach areas, were set up within the community, in rural schools, in rural community centers, and since these were away from the health delivery facilities, the women came there and the attendance was high. The pandemic was an opportunity for the program to rationalize its screening guideline. So from screen, colposcopy, and treat, they moved to screen and treat, and now they are scaling up ablative treatment across the country. They included within the training curriculum for the health professionals engaged in cervical cancer screening a module on COVID mitigation measure. Again, maybe something unique that is there in any LMIC screening program. As the COVID pandemic spread, the government decided to expand the scope and reach of the health information system, the DHIS2 system, and this actually benefited the program because the program can set up the modules in all the primary health centers and collect data at the individual level. And this gives the advantage to the program to convert the current high volume opportunistic program to a population-based one in which women can be individually invited and the VIA positive women can be tracked whether they have undergone treatment or not. And they have started a pilot to implement that. The pandemic was an opportunity to expand the DHIS2 software, especially with the cervical cancer screening module, to the last mile and making the program more impactful. I thank Professor Ashrafun-Nessa and her colleagues for sharing the data and doing the excellent job in terms of implementing the cervical cancer screening program in Bangladesh. Thank you for your patient listening, and I'm ready to take questions. Thank you.
So thank you, Dr. Basu, for also taking time out of your busy schedule to pre-record your presentation for us. We'll move on to my own presentation. Okay, can I control it through this? Yeah, I can. Okay. All right. So thank you very much for also inviting me to speak here today. So my presentation will be on the predicted impact of the COVID-19 pandemic on cancer mortality in Canada, so in our own home country between 2020 and 2030. So obviously this work was done with the collaboration of many people, including all of my co-authors whom you see here. And the work was done in the context of the McGill Department of Oncology COVID-19 and Cancer Program work. Oh, okay. Yes, so I have no conflicts of interest to declare. The funding for this project came from the Canadian Institutes of Health Research. So as we saw in both Chile and Bangladesh, there was a decline in the provision of cancer services and the number of cancer diagnoses. And Quebec and Canada was no exception to this, because we did see that the number of cancer diagnoses and the number of treatments for cancer did decline during the course of the pandemic. So you have some data here on the right-hand side showing you that here in the province of Quebec, for example, there was a 5% cumulative decline in 2020 and the year 2020-2021 compared to 2019-2020, both in terms of the number of cancer pathology reports that were made and the number of cancer surgeries which were performed. And so this led to some quite sensationalistic headlines, that there was a lot of cancer that went undetected during the pandemic, which is an impending disaster, as specialists warn. Now, obviously, these declines are quite concerning, because we know that cancer is a very time-sensitive disease, and that delays in cancer diagnosis and cancer treatment can impact the long-term health outcomes of cancer patients. But because it takes a long time for these things to manifest, so unfortunately, it looks like the fonts of my presentation did not quite translate into the platform. So hopefully you can forgive the overlap of the fonts. I'll try to interpret what's going on in this figure here. So this is a figure which conceptualizes the cancer care trajectory for a cancer patient, going from the patient who, the first noticing of symptoms by the patient, to the first presentation to healthcare, first referral to secondary care, then their diagnosis, and then the start of their curative or palliative treatment. And so the intervals between these key time points in the cancer care trajectory have been given names. So for example, the time between the patient first noticing symptoms and the first presentation to healthcare has been called the patient interval. The time from first presentation to healthcare to diagnosis is the diagnostic interval. And the time from diagnosis to the start of curative treatment is the treatment interval. So and during the rest of this presentation, when I talk about intervals, I'm talking just about the time between these events which occurs, which doesn't necessarily mean that there's been delays in the care of a person, because there's a naturally expected interval between each of these events. So when I say delay, I mean specifically that's time additional to what would be the normal expected interval between events, which was caused by the pandemic. And also, when I say diagnostic delays, I'm kind of putting together the patient interval and diagnostic interval, just because it's quite difficult to measure the patient interval. So when we see that there are fewer diagnoses, it means that there's been delays, probably both in the patient interval and in the diagnostic interval. So if we think of how the pandemic has impacted cancer care, we can think of it as impacting each of these potential intervals, leading to delays in diagnosis and then delays in treatment. And so part of the issue is that, as you may or may not know, there's always lags in the reporting of cancer deaths and cancer diagnoses. And it's also that we expect that because there's sort of intervals and it takes a long time to measure the impact of delays in diagnosis and treatment and mortality, we're not going to have all of that data immediately. And so it can be useful to use and set projection models to try and estimate, well, what is the impact of the delays that we see today? What is the impact of the fewer surgeries that we're giving? What is the impact of the fewer diagnoses that we're seeing? Well, how can we expect that to potentially impact cancer mortality in the long run? And so this was the objective of this research. It was to use a decision model to predict the long-term impacts of the pandemic on cancer outcomes in Canada, especially on cancer mortality, because that's the one that takes the longest to occur and that we want to predict the most. So in order to do this, we built a microsimulation model, which was a dynamic individual-based stochastic model programmed in C++. And so the way that this model works is that new cancers are diagnosed over time in the model with particular characteristics such as their site, their stage, the age, the sex, and the expected death date of the person based on Canadian cancer statistics in 2019. And we simulated the cancer care trajectory of each of these cases until either the person's death or the end of 2030. And so the way that we modeled delays is based on data that we saw from different Canadian provinces on the decline in the number of diagnoses, the decline in the number of surgeries that was seen. And so, for example, here in the figure, you see the reported declines in the number of cancer surgeries which occurred in Quebec and in Ontario and for Canada as a whole. So we see that, for example, in April and May of 2020, there was a severe decline in the number of cancer surgeries which were performed across Canada, and that there was a certain recovery which occurred over 2020 until around November. And then, as you may recall, in 2021, there was a sort of the second pandemic wave. And so so when we extracted the data initially, this is always open data, and so when we extracted the data around May 2021, it's possible that this decline here that you see is simply just a little bit of underreporting due to the fact that there's lag sometimes in reporting of number of cancer surgeries. So we do think that this decline that we eventually modeled may not be as severe as what is suggested here. But because, you know, we're always but we're slaves to the open data and how quickly people can report the number of cancer surgeries, we're always a little bit behind in terms of the data that we have. So this was the best data that we had at the time. And so we tried to see what would be the impact of what the data suggested was the decline in cancer surgeries in 2021. And so sort of the basic assumptions that we're doing in our modeling is that when we miss a diagnosis, it gets placed on a sort of diagnostic backlog of people who have cancer but have not yet been diagnosed. And this is similar to treatment. So if a person, if we see that there's a decline in surgeries, it means that potentially someone got put placed on a treatment backlog. And this treatment backlog can eventually get sort of cleared along as if ever treatment capacity increases over time. We had to make some assumptions regarding, you know, what was going to happen in 2021 because at the time we didn't have any data. We can talk about later whether those assumptions panned out in the end. I think that they were a little bit too not conservative, but a little bit too pessimistic about what eventually happened, but we didn't have any data, so we had to make assumptions about what would happen. And we assumed that treatment capacity levels would return to pre-pandemic levels in June of 2021. And because we had no data on chemotherapies, we assumed that chemotherapies would experience the same decline as we saw for radiotherapies. So the big question is, well, how do we expect that a delay will impact a cancer patient's eventual survival? And so thankfully for us, there had been a very timely systematic review that had been published in 2020 in the PMJ by Timothy Hanna and colleagues, which had estimated that each 4-week delay in cancer surgery leads to a mortality hazards ratio of around 1.6 to 1.08 for many common cancer sites. So that means that every 4-week delay increases the rate of mortality by about 6 to 8% for a lot of cancer cases. And so we didn't necessarily have data for all cancers, but we made a very broad assumption based on this that each 4-week delay in diagnosis and treatment for all cancer sites and for all treatment modalities would lead to this 1.06 times increased hazard rate of cancer mortality. And that these delays would be multiplicative over time, so the longer the delay you experience, the more it increases your risk of cancer mortality. But because of the high uncertainty around these numbers, we did vary the effect of delays on cancer mortality in sensitivity analyses. So the way you can think of the model is kind of like this. So this is just a hypothetical example to sort of, if you didn't understand the past few slides, this kind of summarizes everything together. So let's say that, for example, in a counterfactual world where there had been no pandemic, you could have had a woman at age 56, maybe diagnosed with breast cancer in April of 2020. And then her treatment would have started a little later. And because this woman got treated and had very good prognosis when she was diagnosed, well, maybe she would die of another cause of death, but long before she ever died from her breast cancer. So the model would basically calculate what's the probability, when would this woman die of cancer, when would this woman die of other causes, and because the death date from other causes is before the death date of breast cancer, then this woman dies from other causes. Now, in the world where there is a COVID-19 pandemic, maybe this woman gets diagnosed a little bit later. So in this hypothetical scenario, she gets diagnosed in April of 2021 instead of April 2020. So because of this, her treatment then starts much later than it would have had she been diagnosed earlier. And so because of this, the model resamples a breast cancer death date for her. And now because of the delays in her treatment, her breast cancer death date is now much earlier than it would have been had she not had these delays. And so now this woman dies of breast cancer instead of dying of something else, and she has lost 3 life years because of the pandemic. So, okay, so now we get to the results. So I showed you how the model kind of works. So these are just the first results that we got based on the data poll that we did in 2021, based on the delays in sort of, or the declines in diagnoses that we saw and the declines in cancer treatments that we saw across Canada. So, so on the left-hand side here, you have the predicted cancer incidence per month. So the monthly number of cancer cases which would be diagnosed across Canada over time. Unfortunately, the calendar date did not translate very well here. So I don't know, I'm sorry, I don't know what happened here, but basically this drop here that you see is 2020. And the increase in cancer incidence, we had to make an assumption that eventually these cancer cases would get diagnosed at some point because they haven't disappeared. They're still there, and we assume that they will get diagnosed at some point. And so we assumed that they would get diagnosed at some point in 2021 and 2022. And on the right-hand side here, you see the number of cancer deaths which were predicted based on these drops, declines in cancer diagnosis and treatments. And so you see that starting from, so the 2020 is approximately here. Again, I'm sorry that the calendar date did not translate correctly into the presentation. So you do see that there is this small but noticeable increase in the expected number of cancer deaths that would be occurring compared to the gray line here, which is the no pandemic scenario, the number of cancer deaths that would have been expected had there never been a pandemic. So you see that, had there not been a pandemic, we would have expected the number of cancer deaths to increase regardless, just due to the fact of, population size increasing and due to aging of the population. But we do see that in the red scenario, which is the pandemic scenario, that there is a difference between these two. And so to make this difference starker, we can take the difference between these two scenarios, which is this next slide here. And we see that, so the difference between the two scenarios is actually not quite that big in 2020. The prediction was that there would start to be more of a difference between the two scenarios in 2021 and 2022. So, if in theory, if all the data that we had is correct and all the assumptions that we made were correct, it means that this is the year where we expect that there would be the most excess cancer deaths, which were caused by the initial delays of the pandemic in 2020, and that this excess mortality would potentially continue to occur until approximately 2027. Now, you see different bars here, which are for different scenarios that we kind of implemented. So the middle red is sort of the base case scenario where we assume that everything would go back to normal in June, normal being that we would go back to, say, 2019 levels of diagnosis and treatment. The darker red is the more pessimistic scenario where we assume the treatment capacity would remain 10% under the pre-pandemic levels after June 2021 due to the effect of ongoing pandemic waves. And the lighter red is the more optimistic scenario where we assume that treatment capacity would increase after June 2021 to even above pre-pandemic levels due to recovery and healthcare investments. And so you see that in theory, if we could have invested in healthcare and really built back a stronger healthcare system, we could have prevented a lot of the predicted excess mortality that would have occurred. So I'll skip some of these slides because we're going to run out of time. So I do want to give people time to give, to have questions. But we did predict that the impact would be different depending on cancer sites. So some cancer sites were expected to be more impacted than others. And also, the predictions do depend a lot on the hazard ratio that we assumed for the effect of delays on mortality. Unsurprisingly, the larger the hazard ratio, you assume the more cancer deaths are predicted in the long term. So you don't see it very well, but the gray line here is sort of our base case scenario based on the best sort of available evidence for what is the true value of the hazard ratio. But, it could go anywhere from here to here because there's a large uncertainty around that number. And different provinces were expected to be impacted differently. Across Canada, the expected impact would be that if you compare sort of the pandemic scenario with the no pandemic scenario, so the expected number of cancer deaths that would have occurred had there not been a pandemic, the difference between the two is about 2% over the next 10 years. So your mileage may vary. Maybe so to some people that I've talked to, 2% is a very large number. To other people I've talked to, 2% is not a very large number. So it's it's not a disaster, but it's again, the pandemic is expected to have an impact on cancer mortality over the next few years. And so to summarize, if cancer treatment capacity is recovered but not increased after 2021, then the model predictions was that there could be around 21,000 excess cancer deaths in Canada, which represents a 2% increase over the decade of 2020 to 2030. Colorectal, breast, and lung cancers accounted for most excess cancer deaths. And in theory, if we could have increased treatment capacity, then a lot of this could have been mitigated. So some of the limitations are that, these predictions are always sensitive to the assumptions that we make and to the data that we put into it, and we didn't integrate data past March of 2021, so we do plan to update these model predictions accounting for the changes that have occurred since March of 2021. So I do want to point out that a lot of what is predicted in terms of excess cancer deaths is not necessarily is not so much due to declines in cancer treatments. A lot of it was due to declines in cancer diagnoses and delays in cancer diagnosis rather than delays in cancer treatment. And so what we saw in Chile and in Bangladesh, these things are very concerning because they also saw declines in cancer diagnoses. These are to me at least this is the most concerning because these are the cancer cases that you haven't seen yet, and so you can't do anything about them because they haven't presented yet to healthcare. So it is important to point out that a lot of the model predictions about excess cancer mortality do relate to this diagnostic backlog and not so much to the treatment backlog that we saw. So there are plans. So currently, sort of the objectives are to update these model predictions using more data and to also integrate the impact of screening. And so we're going to be using colorectal cancer as sort of a case study because it integrates the effects of screening and cancer diagnosis and cancer treatment together. So I think I'll end here in order to give time for questions at the end. So thank you. Do we have Dr. Basu? We have 3 minutes. Okay, wait, sorry, we have 3 minutes for questions. Do we have Dr. Basu online, or was he able to join? No, okay. So unfortunately, Dr. Basu will not be able to answer your questions regarding his presentation. But if you have any questions about my presentation, I'd be happy to answer them. Yes. So we have a microphone, I think. Yeah, so the question was about, have these results been presented to policymakers? So the short answer is yes. We've had presentations, done at different levels to CPAC and to different the people working at cancer services in different provinces. But these people are obviously very busy. They have their own priorities, and so I'm basically telling them something that they already know. I think that it is concerning. I don't need to tell them. They know very well that there are delays in cancer diagnoses and there are delays or not delays, but there have been drops in cancer treatments, and so their focus I don't work in the ministries, and so my impression just from talking to them has been that they were obviously very concerned about this and that they worked very hard to try and preserve cancer services. So I think that if you compare, for example, what we saw in Canada versus what we saw, for example, in either Bangladesh or Chile, we saw that the declines were much lower for cancer diagnoses and cancer treatments in Canada than they were in many other countries. And I think that this speaks to the the important work that people did to try and conserve cancer services during the pandemic. I think that this is something, maybe it doesn't look like it from, when we see headlines, but I do think that people did very, very good and important work to try and at least, conserve health services for cancer patients. Oh, yeah.
Thank you so much for your presentation. Very happy to be here. I'm representing the Global Cancer Program at Princess Margaret. So you've mentioned plans for updating your model, and you hinted that there was, you're working on the best available data you had at the time. You had to make assumptions for 2021. So I'm curious if you could speak to how your model has now been updated now that you've had that.
Yeah, well, for example, initially we didn't have any data for chemotherapy, so we assumed that there was a little bit of drop in chemotherapies, but the data that we got, in fact, from Ontario suggests that during the pandemic, the number of chemotherapies that were given actually went up and stayed up during the entire pandemic, suggesting that there was likely a shift in the kind of treatments that people gave. And so we can't assume now that chemotherapies went down. The data says they didn't, they went up. And so now we're concentrating a lot on cancer surgeries. For example, I made some very broad assumptions that all cancers would be kind of affected equally, but there's a lot, not necessarily in terms of the impact, but in terms of that the drop in surgeries would be different. But now we have data specifically by cancer site. And so we see, for example, I think that colorectal cancer was impacted much, much more than many other cancers due to the fact that people weren't screening for colorectal cancer. And so we're hoping to give better estimates for at least, the four cancers we're going to try to concentrate on are colorectal cancer, cervical cancer, lung cancer, and breast cancer, because these are the cancers that either account for many, many cases in Canada, or that there's screening programs for and that we think have been potentially a lot more impacted than other cancers, definitely. So a lot of things are different now than when they were in 2021. Yeah.
Thank you very much, Dr. Malagon. So we're now going to move to